Thanks everybody for being here for another episode of the PC Assembly Journal Club. My co-editors and I thank you for your attendance. And today we are going to be talking about the trial entitled Sotatercept in patients with pulmonary arterial hypertension at high risk for death, or more commonly known as the ZENITH trial. We're going to have a great presenter today. So Dr. Chelsea Meyer is going to be presenting for us. And then we have Dr. Sandeep Sahay, Dr. Adriano Tonelli, and hopefully Dr. Ioana Preston as panelists today to talk about the article afterwards. So Chelsea, you want to get us going?
Sure thing. So just wanted to say hi. I'm one of the pulmonary critical care fellows over at the University of Rochester with Dr. Roto. So thanks for giving me the opportunity to participate in this. And I want to give a little thanks to Dr. Jim White too, who also helped with the presentation of this also. So I'm very excited to kind of delve into this a little bit more. So firstly, just want to go through kind of the outline of what I had for the presentation today. Just a little bit about the background of sotatercept itself and how it affects the PAH and the group 1 WHO classification that we'll be going through and seeing in a lot of these trials. I did want to go and look at a few of the precursor trials that led up to the ZENITH trial, just because I think it's good background as to how we got to where we are for this one. And then we'll get into the design, methods, results, and then a summary slide on the final kind of discussion that they talked about in the trial itself. And then we have a few questions at the end. So firstly, just want to go through the underlying mechanism, which I'm sure all of us know based on PAH is essentially an uncontrolled proliferation of cells within multiple layers of the pulmonary vasculature. So, and it's generally this imbalance that's caused between the growth factors and apoptotic factors that really get confused and misaligned. This causes the remodeling and increases the mean arterial pressure and our pulmonary vascular resistance, leading to RV dysfunction and eventual death. And again, what we'll be looking at in most of the studies that we'll see throughout today's presentation is the PAH WHO classification group 1, which includes a few different subgroups, including the idiopathic PAH, heritable drug-induced, and then connective tissue disease, along with HIV, portal hypertension, and other diseases that might affect this group. But most of the ones that we'll see in these trials are the idiopathic and heritable and connective tissue disease group. And again, this helps us kind of determine, we'll see later on in the ZENITH trial, how they were randomized based on their different demographics. So previous treatments here that you can see that we use as our background therapy, which is one of the main components of a lot of these trials too. So we are looking at the prostacyclins that inhibit the vascular endothelium and smooth muscle growth. We look at riociguat and our PDE5 inhibitors that work on the nitric oxide pathway. And then we have our endothelial antagonists that work on that to slow that down. But the way sotatercept works is on a brand new pathway, and why it makes it a little bit more novel and why we're seeing all of these studies now showing the effects of it. So that works on the TGF beta superfamily, specifically the BMPR2 gene is quite affected in these, which is something that we learn in medical school that's related to that PA group 1 that we see a lot. So as we can see here, these growth factors between the BMPs and the activins, which is what sotatercept works on itself, again, become dysregulated. So without that balance, there's an increase in that proliferation signal with the activins. Thus, sotatercept goes in and works as a ligand trap to slow down that proliferation signal and even them out and balance it out a little bit more, allowing for remodeling back to the normal function, hopefully, eventually. So some of the previous trials that looked at this were firstly the Pulsar trial. It was a phase 2 randomized double-blind placebo trial that looked at a few different things over the course of 24 weeks. They were looking at efficacy along with safety, and their primary endpoint was the pulmonary vascular resistance. They also looked at the 6-minute walk test, pro-BNP, TAPC, along with a lot of our echo findings in functional class. So with this, they showed there was significant decrease in all of most of the factors that they were looking at, specifically, as you can see in this graph here, the pulmonary vascular resistance, which was their primary endpoint. This was a little bit of a smaller trial because it was a phase 2, and they used slightly different groupings compared to both the Stellar trial and the ZENITH trial that we'll be looking at, in the sense that they had a placebo, a 0.3 mg per kg group, and a 0.7 mg per kg group, which we will see later on was more of a transition group for the following trials. They also were able to look at a lot of the adverse effects. So looking at severe bleeding, thrombocytopenia, and increased hemoglobin levels, which were a big factor in what we looked at in many of the forthcoming trials that we'll talk about. And then, so to go on to the Stellar trial, which was one of the earlier trials also, that looked at many of the same primary outcomes that the Pulsar study looked at, but it was a phase 3 multi-center trial, and again looked at a larger population over the same 24-week period. They also defined that they were looking at the functional class group 2 and 3, so the middle group, so mild to moderate symptoms, along with people on the background therapies. So they needed to be on double or triple therapy, which is consistent through all these trials. Again, their endpoints were the 6-minute walk test, pro-BNP, decrease and improvement in that functional class. So for their results, they did look at the 6-minute walk test, which showed about a 40-meter increase in the Sotatercept group, which was great. And then along with a lot of their secondary endpoints were significantly significant also. So, and one of their secondary outcomes, which are secondary endpoints, which they looked at, were kind of the basis for the ZENITH trial and what their primary outcomes were. So time to death, along with non-fatal clinical worsening. They were also able to incorporate a little bit more of the symptomatic side of things for patients, and looked at more of that in this trial too. So we can see here, this was their primary outcome for what they were looking at in the 6-minute walk test. So we can see the change from the baseline at the first few weeks. So 3 to 6 weeks wasn't really significantly different, but over the course of that 4 weeks that they studied these patients, they were able to see a marked difference up to that 40 meters in the first 24 weeks, which was great. They also looked at their secondary endpoints here, which I would say is kind of the basis for the ZENITH trial and why their primary endpoints were more of the major effects that we are seeing. So we can see the total number of patients that died or had clinical significant worsening was much higher in the placebo group than that of the Sotatercept group, which was great to have that endpoint that we didn't see in that Pulsar trial as defined. Along with, we were seeing hospitalizations that were a lot higher, and then worsening of PAH in general. So yeah, so that brings us essentially to our main presentation for today. So we'll be discussing the newest data that has come out. This came out in May of 2025, so earlier this year, and it was looking at a little bit different population, which we'll see in this term high risk for death, which we'll get into a little bit. And as I alluded to before, the goal was to expand more on these major outcomes such as death, lung transplantation, and greater than 24-hour hospitalization due to worsening of PAH in these patients, which was a little bit different than the previous style trials that were looking at more of the physiological effects that we could use to determine. So we'll go into the design. So this was, again, a phase 3 trial, so a little bit more broad in terms of patients. So they did end up randomizing 172. It was a multi-center trial, which was great. We were able to see very different populations there, along with a double-blind randomized placebo-controlled trial, which was as best as we can do in most of these trials throughout the time. And again, they were evaluating a much sicker population. So they had the functional class 3, which was included in the previous trials, but also functional class 4. And they also used the REVEAL Light 2 score to determine a high risk of death within 1 year. And I'll go over that in a second. These patients were also on maximum double and triple therapy, background therapy that were already in place prior to it. And we'll see in demographic wise a little bit later what that entailed. Again, compared to Pulsar and a few of the earlier studies, they used 2 groups. One was the placebo group, and then the second was the therapy group, which showed the escalating therapy as tolerated from 0.3 mg per kg to 0.7 mg per kg throughout. And just to go over the REVEAL Light 2 calculator, it was nice because it pulled in a lot of the other factors that we were seeing in previous trials. So the ProBNP that we were looking at, the 6-minute walk test that we were looking at before, the functional class, which was used within the other trials that we saw, along with BP, heart rate, and kidney function throughout. So when they were looking at this, they wanted patients that were above or equal to 9. And then we'll see a little bit later that they classified and randomized these patients into groups of REVEAL score of 9 to 10 and REVEAL score greater than 11, to just give us a little bit more in terms of severity and the effects of Sotatercept on it. So again, their primary endpoints is kind of almost flipped from the previous studies, where they use the all-cause death, lung transplantation, or hospitalization greater than 24 hours for worsening PAH symptoms as their primary outcomes, and then or endpoints. And then the secondary, they wanted to look at overall survival along with transplant-free survival and all-cause death, along with many of the other things that we had looked at in previous trials. So ProBNP, REVEAL Light score changes, functional changes in class, 6-minute walk test, and cardiac output. So a little bit more on the randomization. So they looked at 255 patients, as we can see here. They ended up randomizing a total of 173, 1 in error. So broke that down to 172. And then they were randomized into a 1-to-1 fashion and then stratified in this randomization according to the REVEAL Light score, as I said before. So they were grouped in the scoring of 9 to 10 was one group, and then greater than or equal to 11. They also grouped it, stratified it in terms of PAH subtype. So they wanted to look at those with connective tissue disease versus not. And then they were able to determine these groups. So we have 86 in both of the groups, and this kind of alludes to a little bit of their findings throughout and who completed the study from that point. They ended up, again, enrolling 172 after the screening, and those were randomized at that point. They planned for an interim analysis for the endpoints throughout, which was great. And that was to be looking at least 59 primary outcome events during this time. And then they were following these patients 8 weeks after the last dose that they had received. So a little bit on their study population. One of the biggest things that we kind of already talked about was the REVEAL score itself and the functional classes. So they wanted to make sure those were evenly distributed as best they could, which we can see here down in the middle of their demographic breakdown, that they were pretty evenly distributed amongst those two groupings, which was great. We can see that they did have quite a few exclusion criteria too for this, which we looked at mostly the different types of pulmonary group 1 hypertension. So that's the idiopathic, hereditable, along with connective tissue disease. They did leave out a few of other ones, including infectious disease processes like HIV and schisto, along with portal hypertension, and then hemangiomatosis. They also wanted to exclude group 2 influences in the pulmonary hypertension group. So removing patients that had an EF of less than 45, any valvular disease. They also didn't want to have their adverse effects really influenced by pre-existing problems such as thrombocytopenia, so platelets lower than 50, along with hemoglobin above the upper limit, just because we know those were adverse effects seen in previous trials. So here we can see the population, majority were females, and again, mostly in a white race, which was consistent with most of previously done other trials too, which as we know that pulmonary artery hypertension in group 1 especially affects more females than males most of the time. So this kind of goes along with that a little bit, but I think it's something to keep in mind when we're trying to apply it to a lot of our patients that we're seeing. One of the differences that they did also note was body mass index was a little bit different between the two groups, but otherwise, for the most part, was pretty balanced between the two, which is great. Yeah. So we'll move on to the results a little bit further. So again, the primary endpoint was looking at death, time to death, time to lung transplantation, or hospitalization that was greater than 24 hours given the worsening of pulmonary artery hypertension. So the results they have here that we're seeing in that first row as at the time of the interim analysis that had at least one of these events. So we can see that there was a much higher event rate, almost 50%, or at least 50% in the placebo group compared to that of the Sotatercept group, which gave us a good confidence interval. And then as we broke down into the components of the primary endpoint section, this is as the follow-up throughout the time course of the study. So death from any causes, we can see it's a bigger number here than what it was in that interim analysis, which showed that there was more of these outcomes later on. So looking at it, it was quite interesting to see at the time of the interim analysis, there was actually a higher rate of death in the Sotatercept group than that of the placebo group based on numbers alone. But once we looked at the follow-up throughout the course of the study, we saw that this actually shifted quite a bit. So there was quite a few more deaths, 10 out of the 11 that happened after the interim analysis, along with more lung transplantations that happened in the placebo group. And then the hospitalizations also throughout. And I will say, looking at this, we see that the hospitalization aspect of it makes a majority of the primary endpoints that we're looking at, which they didn't break down necessarily and show us the interval groups between that. So then we can see, we'll show the primary composite endpoints. So we can see pretty early on that this overlap, there's not really much overlap in that confidence interval, which was great. So it gave us a pretty strong indication from our primary endpoints that we were seeing. But we can see the secondary endpoints were a little bit less convincing, if you want to say, given that the confidence interval wasn't quite as dynamic as we would have seen in the primary outcomes that we were looking for. So we can see the overall survival in the smaller box at the top. It shows that the confidence interval was overlapping for both. The same thing was also seen in the transplant-free survival. And this was important in the sense that when we were doing the statistical analysis for this trial, they wanted to look at it in a hierarchical fashion. So doing that, they stopped doing the statistical analysis after they got the first non-significant event, which was the overall survival of their secondary endpoints. Even though that's the case, which we can see in the overall survival here, which the p-value didn't get to where they wanted, which was the 0.0025, we can see that they gave us the confidence intervals for most of the other factors that they were looking for, those secondary endpoints, and most of the confidence intervals there were significant that we can see. But it's hard to infer, given the fact that the study was ended early. We didn't get that full kind of statistical analysis that we probably would have if we had continued on with it. One of the other big outcomes that they wanted to look at was safety and adverse effects, especially since we were able to look back at those primary or previous studies before and kind of see if this study in particular was looking similar to those of the Stellar, Pulsar, and many of the other studies that were done in terms of adverse effects. So as you can see, any adverse effects that were listed is very high in all of the groups, both the Sotatercept group and the placebo group, which was very balanced between the two. There wasn't any statistically different amount in those. Those related to treatment, though, we can see that there was a higher number in the Sotatercept group, and that was significantly different. However, determining the severity of it was in the seriousness of these adverse effects, there wasn't really much of a difference, especially in things like serious bleeding, adverse bleeding events. But there was the statistical difference in those of epistaxis along with telangiectasias too. So it's kind of nice to see the breakdown a little bit more, which we can pull up in the supplementary data too, if anyone wants to look at that breakdown. I did not add it here, but it was kind of nice to see that while there were quite a few more adverse effects in the Sotatercept group, the seriousness of them and their outcomes in determining the need for treatment discontinuation was about the same in both groups. And we actually saw treatment discontinuation in the placebo group more. So just kind of going over the summary of the findings throughout this study. The interim analysis showed that there was a lower risk of the primary outcomes, again, hospitalization being one of the largest components of this. But given these findings in the interim analysis, they actually stopped the trial early because of the efficacy and the ethical dilemma of needing to give people a medication that looked like it was going to improve the overall outcomes. And again, one of the differences in this trial compared to some of the previous trials that we looked at earlier was the risk of the major outcomes was the main goal. So, which strengthened the applicability to a lot of the patients, especially more in the severe groups, functional group 3 and 4, which would mostly have the biggest impact on these patients. Again, stopping the trial early because of the efficacy that was seen at the interim analysis kind of probably reduced the statistical power of those secondary endpoints, but we can see that there was a favorable overall in terms of the confidence intervals that they were able to provide. And also we've seen a lot of these secondary endpoints shown in previous studies before. And there was also consistency in the safety and adverse events that were seen both in this trial with previous trials, which helped convince or to be more convincing in the setting of what we can and can't do with Sotatercept. And again, one of the downsides of a lot of these trials, including this one, was that we haven't been able to see the longer term effects. So going past that 8-week mark, but there are a few studies that are looking at that right now. So overall, I think it was a great study in terms of how they formulated the the design of the study and what patients they were looking at to give the most applicable usage of Sotatercept for different groups, which was fantastic. I did have some discussion questions, but if anybody wanted to ask anything now before I go into that, that would be great.
That was great, Chelsea. Thank you for that. Yeah, I think these are great talking points. Before I guess we get to them, I'll give our panelists kind of a chance to kind of comment on your presentation or bring up
Sure.
anything they want. And then if not, I
Yeah.
have some questions too. So
this is Adriano. I think the presentation was great, and you included data from the 83 pages supplemental file, which is impressive, since usually we, at least when our fellow presented in our program, they didn't include any of that. And it's interesting that even the figure 1 with the study progress was not even included in the main paper. So that's great. The other one is, I think it's the figure that maybe we need to also talk about is what is the S3 with the forest plot, where it shows that the benefit of Sotatercept was consistent across all subgroups, which is also an information.
Yeah, I think I can pull it up I think I have it up if you would like to see it specifically. See if I can do it.
I think that sort of gets to, Chelsea, your first question you were alluding to, which is like, with the benefit being so strong and across so many different groups, in terms of symptoms and risk, like when is the right time to add it, I think is becoming the big question, right?
Yeah, I think that is one of the main things that a couple of the other studies that were going on around the same time we're looking at. So the Hyperion study specifically was looking at these findings in patients that were diagnosed closer to the time of starting Sotatercept, whereas here in the demographics we could see that the time to starting Sotatercept, they were already on their baseline background therapy, but it was about 7 to 8 years out from their diagnosis. So the Hyperion study was going to look at a little bit more of that in the first year or two, I want to say. I know they ended the study early because of the findings of this trial. So because of the efficacy of it, it's hard to say that it wouldn't work earlier too. So, but yeah.
Thanks, Chelsea. Ioana here. So one of the interesting information that ZENITH gave us is how do patients with severe PAH who are maximally treated in centers with experts on board, what's really their outcome? If you look at the placebo arm, which is not placebo, is background therapy.
Right.
And to see how many events these patients have, what's their mortality, how many hospitalizations. This is really a sick population, in spite of a lot of these patients being treated with triple therapy, including prostacyclin. It gives us a better, a more current, outcome on our patients.
Yeah, I think it does a great job of looking at, patients that have this is a very established regimen and how to move through it. So how can we incorporate Sotatercept in it different ways? And what does that look like in the future in terms of when we're starting this background therapy or other therapy that's already existed for a while?
Right. The other interesting finding is the separation of the curves in the Kaplan-Meier graph that happened pretty early, and it superimposes what Stellar showed in time to clinical worsening and Hyperion in the they're in the main outcome, which is different, a little bit different outcome, right? So the components of the primary outcomes are different, so it's very difficult to compare head to head the results. Nevertheless, the curves are very similar with early separation. Which I still have to get my head around how it happens, since we think it's a non-vasodilator, remodeling agent, or whatever you call it, whatever it does. How come it does so quickly, especially in a population of patients who have on a median 8 years of disease. The disease is severe, so it must be a lot of damage in the pulmonary vasculature. So I think there's a lot more to learn of how this drug works that we haven't uncovered.
Yes, I think in that aspect too, it's going to be very helpful in seeing kind of the adverse effects and kind of the long-term effects with it in terms of, it creates these AVMs almost, or telangiectasias, so different vasculature. So in a person that's on this for 8-10 years, at that point, are they going to have higher risk of bleeding and things like that, and weighing it as we go down the line a little bit more? Because if it's making such a difference at the beginning and able to do this, if we want to call it remodeling or whatever, along those lines of what it's actually doing, these patients hopefully are going to be living longer or free of hospitalization. So what are those major effects that are are they going to be detrimental in the future to them too? So.
Right. And I think Soteria is going to give us more answers with the long term, and especially pick up signals of rare side effects. I mean, we know now the most common side effect profile. It's been studied. We know it's epistaxis. We know there's an increase of bleeding. We know there may be a drop in platelets. We know the hemoglobin may go up. Telangiectasias, pretty high occurrence, although it doesn't seem to be associated with any negative impact on the well-being of the patient so far. But then the rare side effect profile, 1-2%, 0.5% of patients in the long term, would be very interesting to follow and to identify and to better understand who would be those at risk.
Yeah, I will be very interested to see the Soteria study when it comes, when it's published, just to see all those, because most of the patients, both from Stellar and ZENITH, once they got to that point, ended up in the Soteria study.
Right. So we'll have more data in the near future. Sandeep, what do you think?
No, I agree. I mean, you have the most experience with the data, and I think clinically we all have observed these, telangiectasias. We also, as you may know, we published about pericardial effusion, and that was another post-trial sort of adverse safety signal, which I think clinicians should be aware of. But data is convincing. I agree with you. I have thought about in the clinical practice, we have over 100 patients on the drug, but I just cannot understand the quick response thing which you highlighted, which is actually very impressive. I joke that one of my patients actually refused to take the drug. She felt that it gives her high. And I don't know how to explain that. Like I don't know what she feels, but sometimes I feel like maybe I should take a shot and see what happens.
It happened to one of my patients recently too. After the first dose, I mean, she did feel so much better, and which is unusual for the first dose, a low dose. But she was almost, euphoric that, oh my God.
Yeah, and that patient just actually refuses to take it, and she said because this drug gives her high, and she just feels kind of jittery, or I don't know how to explain it, but but which is very interesting that how patients after one shot, we have dosed some of the sick patients in hospital, and there is clearly a clinical response with just that one dose. And in clinical practice, I feel like maybe after 3 doses, their NT-proBNP just drops dramatically, which is very impressive. So far, I think things are looking clinically in patients very interesting. One recent observation, which actually I was talking to Adriano a few weeks ago about this. Now we have some maybe 30, 40 patients where we have post 6, 8 months right heart cath on these patients in the real world setting. We did observe this sort of a paradoxical hemodynamic response, and I'm not really sure what to do in that situation, where their mean PAP improved almost near normal, their RV function improved, but at the same time their cardiac output went down. So many patients, despite of them dropping their mean PAP or clinical improvement, RV function improvement, what we observed that their PVR is actually higher. Now, I just do not know what to do with in that situation. And this, I was discussing with Adriano because he's our hemodynamics consultant. So, so he and I were just debating that. And I have now maybe 3 or 4 such patients where I have this 6, 8 month follow-up right heart cath, and patients are doing fine. Like they are clinically, their walk distance improved, their NT-proBNP normalized. But then because cardiac output dropped down from their baseline, their PVR is somewhat higher. So I just and even I was looking into the supplementary data for this trial. There was a slight drop in the cardiac output in this, and we know this from other pooled analysis also that for some reason the drug does not have effect on cardiac output, or if anything, has somewhat negative effect on cardiac output. So I don't know. I don't
So
know.
Adriano, what do you think?
So I just did a patient yesterday, fresh out of press. And this patient is an idiopathic patient on 3 orals and then Sotatercept. And this was a 6-month follow-up cath. She said that she felt as good as ever. She's feeling so much better. And the RV was mildly decreased. And we do this 6-month follow-up here. And the idea of doing the cath was see if I could stop this Alexipac that was giving her headaches. So I ended up doing the cath, and her PVR was 4 before, and after the cath, the PVR was 6, worse. So then I had to go and talk with the patient that's feeling better, that she had low risk on all the scoring systems. But the PVR went from 4 to 6. So yes, the mean pressure was lower, but as the cardiac output dropped, the PVR increased. And I had a hard time trying to explain that to her. How can that possibly be? End up switching the selective because of headache to Tyvaso DPI, but I don't know. This discordance is just driving me nuts.
Me too. The day I texted you, I was in cath lab. I did 4 caths that morning 2 weeks ago, and 3 were post 6 to 8 months. And I actually thought maybe my cath lab instrument is broke or something, that I'm not getting cardiac output correct. And we checked everything, and everyone's cardiac output was down, but mean PAP is down. And out of those 3, 2 patients had increase in PVR, and 1 patient, actually, I don't have the number. I just have the PVR number with me right now because I had started her on at PVR of 8, and this time her PVR was 12. When she walked 500 meters, her NT-proBNP is normal. Her RV function is normal on echo. Now I look at the PVR of 12, and I'm just kind of confused, how do I need to advance treatment. I mean, this is concerning to me, but then everything else looks normal. Her echo shows normal RV function. She's doing fine. She feels great. She went for hiking trip and all that. Now what do I do with this cath.
But Sandeep, is the cardiac output below 2? I mean, the cardiac index was below 2,
Cardiac
or
index
did it
was,
go
you're right.
down?
You're right. Cardiac index actually went below 2. Let me pull it up here. I can
I
show
mean,
you.
does it go into the, abnormal range, or does it go
It
down
was
to
abnormal.
normal?
It
I
was
see.
abnormal. I'll tell you her numbers. So her NT-proBNP is absolutely normal, less than 36, which is by the lab range, like below 36 that they can't check or something. Her echo shows normal RV size, mildly suppressed RV function, but normal RA, RV, no TR jet, nothing as per their thing. And then I did a cath on her this time. Let me just pull it up here. But you're right, her cardiac, because that I just could not understand, like her cardiac index was lower, below 2.
Yeah, it is
1.6.
unusual. And that was a thermodilution cardiac?
Thermodilution, both were down. FIC was all indirect
Yeah.
FIC, and the both were down. Let me just pull up
Yeah.
exact numbers on her. So I mean, I somehow convinced her to at least add inhaled treprostinil or something, because she didn't want to do anything. Because I just felt like it's just, but and this has happened like third or fourth time. So initially I thought maybe it's one-off patients, but now it's sort of like a theme.
And then the other question is, what's the hemoglobin in these patients?
And that's true. Her hemoglobin is 17. When I did a cath, it was 17. And
Yeah.
before I mean, she's a pretty healthy, like mid-40s, younger woman, idiopathic PAH, and she used to always be around 13. I'm looking at her labs last year, like around 13, 14 range. But now she's at 17, around 17 ranges.
Yeah. So the question is, with a significant increase in hemoglobin, is the oxygen delivery overall better, even if the cardiac output is lower? And I think only a direct FIC will be able to give us an answer, maybe in Adriano's cath lab, or in the cath labs that you guys do direct FIC, may help explain.
You're right. I actually thought of that after the fact, but you're right. I think maybe we should start doing that in these patients, perhaps, to get more accurate data.
Yeah, because we're not used to having our PH patients with hemoglobins in the 16, 17. And it does go up in my patients too. So maybe the hemodynamics are significantly influenced by a higher hemoglobin.
So, Adriano, question to you. When you said this cardiac output, did you do the direct FIC, because you do all the direct or thermodilation?
So the direct FIC takes 15 minutes extra work, and also requires an arterial puncture. I don't see how you can have, by, let's say, the hemoglobin increases by 2 or 3, a dissociation between thermodilution and output. I agree that if your body doesn't need that much cardiac output because you have high hemoglobin and you transport more oxygen, the cardiac output should lower, but it should also lower in thermodilution. And if we do it, I mean, we do it 3 times in less than 10% dip. You did it 10 times, you said, Sandeep, in yours?
Huh? What is it?
How many times did you do the thermodilution in that patient?
So every time I go continuously at least 6-8 times until I get like good, consistent, within 10% readings. Huh? What is that?
That's a fluid challenge.
Yeah, it's almost like fluid challenge. Maybe wedge starts going up after that. So, but I'm just saying that it was a theme that day in cath lab. Like I just I don't know.
Yeah, no, you're right, Adriano. I mean, the thermodilution is a great. The only thing is that the oxygen extraction measurement, we don't have it, and that may be something that would be interesting to study. Only in patients in whom the hemoglobin goes up significantly. Maybe it's worth looking in more depth into these people to better understand this, drop in cardiac output with normal NT-proBNP and normal RV function, or almost normal RV function on the echo. It's puzzling.
And one other observation, again, these are just anecdotes, these are just individual observations, so take them with caution. And they may be wrong, or just this whole notion of it being sort of disease modifying or reverse remodeling, or I had this patient back in June who had GI bleeding, so I stopped the drug. I was so hesitant to put her back on the drug because of the GI bleeding requiring hospitalization and all. So I kept on watching her, and every month she's doing her labs and all. This month, which is October, so June, July, like her NT-proBNP from normal range last month to this time has shot up to like 1100 or something. Asking her to get the echo done and all that to see, because I was thinking when to reintroduce the drug, because she had a very good response. Her mean PAP dropped from 49 to like 35 or something. Very good response. So now I'm just kind of I'm bringing her to clinic to see her and get the other testing done and all. So it will be interesting to see if her pressure has again gone up, or if her echo looks worse or something like that.
Sounds like it.
Yeah.
Sounds like it.
Sounds like it, but I will
In
share
terms,
so
in
much we're
terms
learning.
of like dosing for it, have you noticed any difference in those on the lower dose first, that they have less of that jump in the hemoglobin and bleeding aspects from your side of things? And then do you start them back on the lower dose then, or do you go titrate it up again all the way to the highest?
I mean, in my opinion, I do feel that it is dose dependent effect, the hemoglobin response. So some of the patients I have kept them on a lower dose and also spaced dosing every 4 weeks. That has helped to have less swing in the hemoglobin. But I guess it's very anecdotal, individualized approach. I'm not sure what Ioana and Adriano's experience.
I think the hemoglobin is definitely dose related, the increase in hemoglobin. The bleeding, I don't think we have data, because the majority of patients were up titrated to 0.7. So there are only few down to 0.3. So it's difficult to judge whether the bleeding risk is dose related.
I think we have a couple of questions there.
Yeah, I was gonna say, we have one question in the chat, which is, has anyone used Sotatercept outside of the inclusion criteria for these trials?
Yeah, I have used it in POPH. Actually, I'm actually going to present in 2 weeks in that meeting we're going to. But I have like 3-4 patients with POPH, very carefully selected, whose platelets were okay, not like child class B and C or bleeding, relatively stable side of the spectrum. One patient actually had dramatic response, which was very impressive. She was not a transplant candidate just because of hemodynamics, and she actually normalized, means around 25. Her mean PAP was 25 something. So that's in my experience so far. I mean, I have used it, but then these are very hand selected, not that everyone that I'm using, but it's just those patients very carefully. I have one patient on HHT also, which I have used, but she's kind of a little off and on in use, but means not because of the bleeding risk, but it's just the patient factor. She has other issues. So, but one of the criteria which I was talking to her hematologist before I put her on, so she gets like monthly dose of Avastin for her HHT, and also I keep in touch with her hematologist to see if the blood transfusion frequency or something is going up, just because if she's having more. So far in last 6 months or so, we have not noticed any increase or need for Avastin from the hematology viewpoint, or blood transfusions or anything like that. So she's been doing okay so far. But again, there's just N of 1 I have. I don't understand the second question. The anti-proBNP also improves, which cannot be explained by the raised hemoglobin. I mean, I think this was in
Probably
reference
in
to
relation to like,
I think maybe it was just a comment.
yeah.
Okay.
Yeah, so I think in my clinic, my colleagues here at Leahy, we have a large liver transplant, and
Okay.
we had in my group, if not me, but in my group, we have used in selected patients, definitely not those with very low platelets. But we got a patient transplanted, so
Oh,
she
wow.
did not respond really well to infusion prostacyclin, which is unusual because these people respond really well to the pH meds. But we were able to bring her to the transplant hemodynamics with Sotatercept. And there's always, worry, risk of bleeding, peri-op, post-op, because it's a long-acting. And I mean, but it's just very, very, very few patients. We didn't see anything
So Ivana, this patient
worrisome.
was transplanted, or she's
Was
being
transplanted, yeah.
and she did fine perioperatively,
She
like
did, yeah,
bleeding,
she did
bleeding.
fine.
Okay.
Yeah, but I think the more pertinent question is, patients in our clinic with PAH that are group 1, but they have other comorbid conditions, and they would not have fitted the inclusion criteria in ZENITH or STELLAR. Can we use it safely in more broader PH population? And I think that's where we have to gather information, from all our, centers to see how safe it is. Actually, if you look at the Hyperion data, the Hyperion population seems to mirror a little bit better what we see in today's clinics with low comorbidities, higher BMI, and so on and so forth. So maybe we are getting to the point where we're gathering information that in not just the pure PH patients can be, treated with this drug.
And I think, is it the Cadence trial that's looking at those with PH in terms of like HFpEF type of
Right,
patients?
that's CPCPH.
Yeah.
Yeah, and then we'll find results hopefully soon enough.
I have a quick question for the group in regards to the ZENITH and the fact that there were 12 to 13% of the patients on dual oral and high risk that were treated with Sotatercept and they had good benefit. What would you do in your practice if a patient comes, it's a high risk, and on 2 oral agents, let's say PD5 and an ERA, would you start prostacyclin IV for high risk, or would you go with Sotatercept subQ?
That's a great question. I think it depends. And then going back to our hemodynamic discussions, they may be high risk, but I mean, you always want to do a right heart cath. That would be my recommendation, right, Adriano, before you start a more advanced therapy such as a prostacyclin or Sotatercept, and I think that will guide you. And if your cardiac index is low, maybe we start with prostacyclin and then consider Sotatercept. If the cardiac output, cardiac index is normal, I think Sotatercept would be a good choice.
I agree. What do you think, Sandeep?
Yeah, pretty much the same thing as Ioana said. Like if cardiac output is reasonable, then I would go with Sotatercept. And then I think the way this drug works with such a dramatic response, you can do a close follow-up. And if you're still concerned, in 4-6 weeks, you can start parenteral prostacyclin. I don't think in 4 weeks, unless your patient is in shock or in the hospital, that kind of situation. I think so.
Yeah. All right.
Okay, thank you. Great discussion.
very
Great
much.
learning. You're learning
Thank
so
you,
much.
guys.
Yeah.
Everybody have a
Good
great
job,
holiday.
Chelsea.
Thank you.